most clinicians, the use of warm compresses are a mainstay for their treatment of dry eye. After all, it makes sense that if the oil glands are plugged, a little heat might make the patient better. And we can all report about patients that have said that warm compresses have helped them. Our question is, when are warm compresses to be used, and how can we use them to be most effective? First, when are warm compresses not effective? We have observed that the most common dry eye type that practitioners use warm compresses for is MGD. Our goal for MGD patients is to improve the flow of the meibomian glands. In a study comparing the effectiveness of warm compresses to LipiFlow, patients using warm compresses showed no improvement in the number of meibomian glands flowing. However, the patients did show an improvement in symptoms, although it was less than those who had undergone LipiFlow. Our conclusion is that for patients with obstructive MGD, warm compresses are not ideal first-line treatment to clear obstructive meibomian glands. Instead, as Blackie et al. Has said, we should be using them as a treatment to help soften and partially melt any remaining material obstructing the glands. A 2008 paper by Blackie pointed out some important features to consider when looking at warm compresses. First, in the most ideal situation, in order to be therapeutically beneficial, we want the inner eyelid to reach a temperature greater than 40 degrees Celsius, or 104 degrees Fahrenheit. In order to do this, we need to maintain the outer eyelid heat at around 45 degrees Celsius, or 113 degrees Fahrenheit. Now, naturally, the hotter something is, the faster it will heat something up. But we run the risk of burning the eyelid and the outer skin, so caution must be maintained. As we look for the ultimate warm compress, ideally it would heat up the inner eyelid to at least 40 degrees Celsius. One study analyzed 8 different methods of warm compresses, including several commercially available treatments as well as a homemade method called the bundle method. All the warm compresses reached their maximum inner eyelid temperature between 4 and 6 minutes. All the warm compresses were warmed up according to their package instructions. However, only one of the methods reached as high as 39 degrees Celsius. However, the inner eyelid heat was short-lived and had dropped to just 38 degrees by 10 minutes. The one exception in the study was the homemade bundle method. The bundle method uses 5 to 6 towels that are wet and then wrung out. The towels are folded and rolled up. Each subsequent towel is rolled around the prior until they all are in a bundle. The towels are then placed in a bowl, covered and heated in a microwave. In the study, the towels were placed on the eye when they reached 47 degrees Celsius. The outer towel was applied to the eyes, and then every 2 minutes the outermost towel was removed from the bundle in the covered container and applied to the eyelids. The bundle method heated the eyelids the fastest to just over 39 degrees at 2 minutes and nearly 40 degrees by 4 minutes, while all the other methods reached their peak temperature at 4 to 6 minutes and then dramatically decreased. The bundle method kept the inner eyelid temperature at near 40 degrees Celsius all the way to 10 minutes. As discussed in our prior clinical insights, we do not recommend any kind of eyelid massage following warm compresses because of the horrible ocular damage that it can inflict. Our conclusion from all these studies are that warm compresses are not all the same. It appears that the bundle method is the most effective, although it is extremely cumbersome compared to the ready-made masks. Our recommendation is that if you educate your patients on the bundle method, but if you fear compliance issues, then consider some of the ready-made masks. Look into research on the masks that are out there and ask the manufacturer to show the evidence of the inner eyelid temperature. Also, consider having the patient reheat the mask after 4 to 6 minutes in order to keep the inner eyelid temperature as hot as possible. Lastly, to ensure that warm compresses are most effective, the evidence shows that they are not effective at opening glands that are closed. Rather, we feel that it is critical to use them for patients who either do not have plugged glands or have recently become unplugged. Warm compresses are great for patients. Many people feel really comfortable using them, and they're a mainstay for our dry eye treatments. Make sure that they are hot and used correctly for maximum therapeutic benefit in order to enhance your patient's quality of life.